alert our speakers to the chat window for some questions and comments coming through there. Our third speaker is Philip Anglewitz from the Johns Hopkins University. He's going to be sharing with us some results from longitudinal studies in 4 African contexts with a focus on fertility intentions and contraceptive use. Over to you, Philip. Thank you.
All right, thanks for the introduction, and hello, everyone. In this presentation, I'll focus not on fertility per se, but look instead at some of the proximate determinants, specifically fertility intentions and contraceptive use in using representative data from 4 African contexts. Next slide, please. So we've already discussed many of the ways in which a shock like COVID can impact fertility and fertility preferences, contraceptive use. So I won't spend a lot of time discussing this slide any further, other than to point out that in the context of the HIV epidemic, some research showed that the uncertainty caused by HIV may actually increase and accelerate childbearing desires. Because for some in sub-Saharan Africa, childbearing is a means of securing financial stability from partners or family members and protection from further economic hardship. So the relationship between uncertainty, fertility intentions may differ in sub-Saharan Africa compared to other contexts. Next slide, please. The data that I'll present here comes from the Performance Monitoring for Action project, or PMA. PMA started in 2013, and the primary goal of the study was to track and monitor key family planning indicators in several countries over time. And in the most recent phase of PMA, starting in 2019, we changed our study design from repeat cross-sectional to a longitudinal panel. And the below diagram shows our timeline and the structure of PMA data collection. So like many other studies, naturally, PMA was disrupted by the COVID pandemic. So PMA collects data in 8 countries listed here on the far left: Congo, Nigeria, Kenya, Burkina Faso, India, Cote d'Ivoire, Uganda, Niger. And we collected the baseline round of our longitudinal panel in the first 4 countries: DR Congo, Nigeria, Kenya, Burkina Faso, in the fourth quarter of 2019, with the intention of starting the second 4 countries in the first quarter of 2020. But of course, COVID caused us to change the schedule of our data collection. So we had to delay data collection for the second set of 4 countries to the third quarter of 2020. But for the first set of 4 countries, we had the opportunity to collect data and follow up with the women who participated in our baseline, which we did in the second quarter of 2020 through some phone interviews of women who participated in the baseline survey, thereby being able to measure some of the changes that occurred in some of these key family planning measures before and during COVID. Next slide, please. So how did we collect these data? Well, as I mentioned, we had phone numbers from all women who agreed to give them to us in baseline, in our baseline survey for these 4 countries. Then we used interviewers to conduct COVID-19 interviews over the phone, and they entered information on smartphones using Open Data Kit, or ODK. The target samples in each of these geographies were women who provided phone numbers in Kenya, Burkina Faso, DRC, and Nigeria. In the first 2 countries, Kenya and Burkina were nationally representative. In the second 2 were representative at the subnational level: DRC of Kinshasa province and Nigeria in Kano and Lagos states. So then, using the data we collected from these phone interviews, we were able to link baseline core survey characteristics like socioeconomic characteristics, family planning, with the COVID survey information that we collect in these phone interviews, and then look at change over time. And because PMA is obviously concerned about being representative, we use weights in all of our data and data analysis. And these weights are sampling weights as well as response weights. And then for the COVID surveys, we created inverse probability weights to account for differences in owning a phone, responding to the survey, and so on. So the data we present here are representative of these geographic areas. Next slide, please. So next I'll go through some of the changes we observed in fertility intentions and contraceptive use, starting at the population level and then looking at the individual level. So first, this first analysis shows fertility desires and how they change from the baseline to the follow-up. So looking at changes in fertility desires that occur before and during the COVID pandemic set on in these countries. And we look at changes in 3 categories for women at the population level. First category is wanting a child within the next 24 months, then wanting a child after 24 months, and then not desiring any more children. Next slide, please. So the graph on the right side of this slide shows changes in these characteristics over time, and we show this for the 5 settings in which we work. Starting with looking at the bottom of the graph, Burkina Faso, Kenya, DRC, Kinshasa, Nigeria, Lagos, and Nigeria, Kano. And the blue color shows the percentage of women who want no more children. The purple is wanting children, but more than 2 years from the current time. And then the green is wanting children less than 2 years. So what we see, some of the overall results show that there were declines in the proportion of women who stated that they wanted no more children over time. So for example, that percentage declined in Burkina Faso from 18% at baseline to 12% in the COVID survey, and in Nigeria, Kano from 17% to 13%. There were also modest increases in the percentage of women who reported that they wanted a child, but not for another 2+ years. So that percentage increased, for example, in Kano from 57 to 67%, and in Kenya from 52% to 55%. There were no significant differences between the 2 surveys in Kinshasa or Kano, but in the other geographic areas, these differences were statistically significant. Next slide, please. Then looking at individual level changes in fertility intentions, we look at, we divide this up into 2 general categories, looking at quantum. So how did the percentage of women who wanted no more children change over time before and during COVID? And then tempo, among women who wanted children, what was the timing of their preferred childbirth? Did they delay or accelerate childbearing before and during COVID? Next slide, please. So this table shows cross tabulations of fertility intentions at baseline, which are shown here on the left side in rows, and fertility intentions in the COVID follow-up shown in columns. And the top of the table shows Burkina Faso, the bottom part of the table shows Kenya. And the first column shows overall change and stability in fertility intentions. And we found that overall fertility intentions were fairly stable, where about 89% of women in Burkina Faso and 84% of women in Kenya had stable fertility intentions over time. Moving to the second set of rows about the quantum, we cross-tabulate again women who want more or who do not want more children over time between baseline and follow-up. And we find that there is a fair amount of stability in women who want more children over time. So 94% of women who wanted more children at baseline wanted more children at follow-up, and only 5% of women in Burkina Faso changed from wanting children at baseline to not wanting children at follow-up during COVID. And in contrast, looking at women who did not want children at baseline, they were more likely to change to wanting children at follow-up in both Burkina Faso and Kenya. So that changed from so among women who did not want children at baseline, 36% changed in minds and said they did want more children at follow-up. Then in terms of tempo, among women who did want more children, they were more likely to they were likely to delay. So among women who wanted children at within 1 year, 35% changed their minds in Burkina Faso and said they wanted a child in more than 1 year. In greater than 1 year from the period of time. And similarly, 47% had the same change in Kenya. And then among women who wanted children in more than 1 year, only 14% said they wanted it within 1 year at follow-up, and 9% said the same in Kenya. So again, when they changed, they were among women who wanted more children, they were more likely to delay. But overall, there was a fair amount of stability in these fertility intentions over time. Next slide, please. Then looking at population level changes in contraceptive use, we look at changes in women's need for contraception and actual use of contraception before and during the COVID pandemic. And for this, we limit the analysis to women who were in union and also who were in need of contraception, which was defined as those who had ever had sexual intercourse, were married or in a union, not pregnant, not infertile, and did not intend to give birth within the next 12 months. And we use data from Burkina, DRC, Kinshasa, Kenya, and Nigeria, Lagos for this. Next slide, please. Briefly summarizing our results, between the baseline and COVID follow-up surveys, the proportion of women in need of contraception, as defined in the previous slide, increased significantly only in Lagos. And contraceptive use among women in need increased significantly, especially in the two rural geographies in Burkina Faso and Kenya, where there were significant increases in contraceptive use in these rural areas. And there were no differences in contraceptive use overall in Lagos or Kinshasa. But we did, when disaggregating by a series of characteristics, urban, rural, parity, and age, we did find a fair amount of variation by subgroups. So for example, there's an increase in the need for contraception among nulliparous women across all sites and a decrease in contraceptive use for the youngest women in Lagos. So again, this shows variation across sites and for these subgroups in our analysis of contraceptive use change at the population level. Next slide, please. Then looking at individual level changes in contraceptive use, we looked at the extent to which women's contraceptive status changed over time at the individual level. So we categorized women into those who adopted methods, discontinued methods, switched use versus maintained their contraceptive status. And in this analysis, we limited to women who were at risk of unintended pregnancy through being sexually active, not sterile, not pregnant, and not having trying to have a child in the next year. And we used data for Burkina Faso and Kenya for this analysis. Next slide, please. So here, the graph on the right side shows these four categories of women. We're starting from the bottom percentage on the graph. That's the lightest color is never used. Then moving up towards the top, the next category is continued use, followed by discontinuation and adoption. So overall, two results to point out here. First of all, that the vast majority of women continued with their contraceptive status, where they either continued never using, or they continued use of their method before and during the pandemic. Then if they did change their contraceptive use status, they were more likely to adopt the new method than they were to discontinue. So for example, in Burkina Faso, we see that 25% of women adopted a new method compared to only 6% who discontinued. And then similarly for Kenya, we see those percentages as 13% adoption and 5% discontinuation. Next slide, please. Then looking at among women at risk of unintended pregnancy who are using contraception before and during the pandemic, we look to see the extent of change in terms of method type. So the graph on the right shows three categories, changing from less effective method, or changing to a less effective method from baseline, changing to an equally effective method, or continuing with an equally effective method, or changing to a more effective method. And we see here that most were using methods that were as or more effective compared to pre-pandemic method. And only 5% of women in Burkina Faso and 7% in Kenya switched to less effective methods during the COVID pandemic. Next slide. So overall, we find that, early in the pandemic, there was a narrative and general concern that women in especially low-income contexts would want to delay childbearing but wouldn't be able to access family planning due to COVID disruptions. And this would lead to unwanted increases in fertility. And this was well-founded, certainly, but we found in contrast that fertility intentions were fairly stable, or if anything, they modestly increased during the early stages of the pandemic. There was increased contraceptive use among women in need, especially those living in rural parts of Burkina and Kenya. And women were more likely to start using contraception instead of discontinuing, and were more likely to switch to a more equally effective method than to switch to a less effective method. And this is consistent with other data that I didn't show here about access to health facilities and family planning services, which showed that relatively few women in these geographies had difficulty accessing health facilities or family planning services. It wasn't without stress. They were certainly concerned about contracting COVID at the health facility, but they did not, a very small percentages expressed any difficulty in actually accessing services. Next slide, please. So some caveats, the most important of which I think is that these data come from fairly early on in the pandemic and early after restrictions took place. Data collection for PMA took place between June and August in all these settings. So again, it was fairly early on. And because many women are using long-term methods in these contexts, you might not expect to see large disruption this early in the pandemic. So now that we fairly recently have data from later in the pandemic in these settings, we can look at longer term disruptions of COVID. As mentioned earlier, there's variation across settings, so there's not exactly one pattern that explains everything, although there were some results that are consistent. And we do have to acknowledge that there may be an impact of survey mode on responses. So some of the changes between baseline and follow-up could be the result of phone interviews, the survey mode of using phone interviews. And there are other things, of course, that we can't observe in our data that changed over time before and during COVID. So something for us to try to measure later, but always these unobserved characteristics are certainly a concern. Next slide. Then finally, what I showed here is obviously very brief and general. So if you want more information on this analysis, direct you to these 3 papers in particular. The first is forthcoming in The Lancet, looking at population level changes in contraceptive use. The second one is published in BMJ Sexual Reproductive Health on individual level changes in contraceptive use. And the third was recently presented at PAA, looking at fertility intentions and COVID from Kenya and Burkina Faso. So thank you very much for your attention, and look forward to any questions or comments that you might have.
Thanks so much, Philip, for unpacking for us these early patterns in family planning intentions and contraceptive access and usage. I think it's very interesting and hopeful to see the future longitudinal waves that the PMA project will be collecting. And our fourth and final speaker for this session is Beth Kangwana from the Population Council in Kenya. And Beth's going to focus on adolescent fertility in Nairobi's urban informal settlements during the pandemic. Thanks. Over to you, Beth.
Thank you. Can I confirm that you can hear me, Ramesh?
We can hear you loud and clear, and we see
Okay.
your cover slide. Thank you.
Great, thanks. So good morning, good afternoon, good evening, everyone. So my name is Beth Kangwana. I'm an epidemiologist working at Population Council in Kenya. My presentation today will be looking at the impact of COVID-19 and adolescent fertility in Nairobi's urban informal settlements. So next slide. So just to give you an overview of the presentation, I'll take you through the study objectives, then the study setting, and then an overview of the study cohorts, which I shall be presenting the data on. And then I'll take you through a review of the methodology of the study, including the data collection and analysis, present to you the results, and finally go through implications and of the results and also limitations. Next slide, please. So the first COVID-19 case in Kenya was confirmed in March 2020. And from March to July, the Kenyan government implemented mitigation measures to curb the spread of the virus. So these measures included closing schools, banning large social gatherings, and also enacting a national dusk to dawn curfew. So in April, the Nairobi metropolitan area was then placed on lockdown, which ended in July. And online schooling continued all the way until October 2020. So during this period in time, our Population Council leveraged adolescent cohorts from our ongoing studies to assess the impact of the COVID-19 pandemic and lockdown measures on adolescents. And the objective of this presentation is to assess the trends of contraceptive use in adolescent girls aged 15 to 19 years across 5 informal settlements in Nairobi. And we'll look at the time span from 2018 to 2021. We use data then to predict possible impact of COVID-19 on adolescent fertility. Next slide, please. So why urban informal settlements? So compared to the rest of Nairobi, adolescent girls living in formal settlements are particularly vulnerable. They are more likely to experience early sexual debut and childbearing. So data has shown that around 1/4 of 20 to 24-year-olds had already initiated sexual activity by the age of 16. And we see that the onset of childbearing among 15 to 17-year-olds in these settlements is much higher than the rest of the region in Nairobi. Again, compared to the rest of Nairobi's population, adolescent girls in these settings tend to have higher rates of unprotected sex, greater exposure to gender-based violence, and poorer access to healthcare services. Next slide, please. So what happened pre-COVID? The council, as I said, was following cohorts, and we had cohorts that were distributed across 5 informal settlements in Nairobi, and this was across 2 studies. So the 2 studies, the first one was Nisitu, Nisikilize Tujengane, the cohort was initiated in 2018. And the other cohort was the Adolescent Girls Initiative Kenya, which was initiated in 2015. So I'll just briefly take you through the different studies, just to give you some background. Next slide, please. So first off, the Nisitu study. The Nisitu study was based in the Eastlands area of Nairobi County. It was focused in 3 informal settlements, Kariobangi, Mathare, and Dandora. And the baseline age range and sample size varied for girls and boys. So we had girls 10 to 14, just over 800, and also girls 15 to 19 years old, of a sample size of just over 500. And this study also included boys 10 to 24 years, which was just over 1,000 in numbers. So Nisitu itself was a quasi-experimental study, and it was testing an intervention to see whether it was possible to improve gender norms among and also reduce perpetration of sexual violence and harassment by adolescent boys and young men using a girl-centered male engagement program. Next slide, please. So that was the Nisitu study, and then the second study was the AGIC study, the Adolescent Girls Initiative study, which was based in 2 different settlements, Kibera and Huruma. And this was only, the cohort consisted of only girls, and at baseline, we had an age range of girls 11 to 15, and the sample size was around 3,000. Again, this was a randomized controlled trial where we were testing an intervention to understand what package of multi-sectoral, multi-level interventions had impacts on adolescent girls. And we also wanted to see if intervening early in adolescent girls' lives can improve longer-term outcomes. So those are the 2 studies. Next slide, please. So now I'll take you through the study timelines and how we then incorporated data collection for COVID-19. So we'll start off with the AGIC cohort timelines. So as I said, it's the top bar in green. The baseline data collection for the AGIC cohort started in 2015. And then we carried out an midline in 2017 and an endline in 2019. So that's the AGIC cohort pre-COVID. And then the NICITU cohort pre-COVID, we had the baseline data collection that occurred in 2018. And then we had an endline data collection that took place a year later in 2019. So then COVID came in 2020. And so, as I said, we then thought, why can't we go back to these cohorts and interview the girls and find out, how COVID is impacting them. So we did that in August 2020. We then carried out a COVID-19 Knowledge, Attitudes, and Practice Survey, or a CAP survey. And we then went back again early this year in February 2021 and repeated the CAP survey across the AGIC cohorts and also the NICITU cohorts. Next slide, please. So what was the CAP surveys all about? So as I said, they're about understanding COVID-19 knowledge, attitudes, and practices. So in actual fact, I know I just showed you 2 rounds of data collection for the CAP survey, but we did have 4 rounds of data collection that were carried out in 2020. And as I said, 1 round in 2021. What happened is the first 3 of the 4 rounds in 2020 were just interviewing parents and household heads. And then by the 4th round is when we started interviewing the adolescent girls, and also in the 5th round. So for this study, we're only interested in the 4th and 5th round of the CAP survey. The topics covered when we were interviewing the girls included the effects of COVID on education, time use and economic activity, social interactions, health, violence, and sexual and reproductive health. But note that for the sexual and reproductive health questions, we only interviewed girls who were 15 years and above. Next slide, please. Okay, so just briefly on the methodology for the CAP survey. Again, as previously mentioned, we had leveraged the adolescent cohorts from the AGIC and NICITU studies. What we did is we took a random subsample selected from participants within the the 2 studies, but only if they had a phone number that we were able to contact them by. So we stratified the sample by informal settlements, and we were able to, we had around 400 participants per settlement. The data that we collected was through structured phone interviews, which took around 45 minutes. And as I mentioned, the sexual and reproductive health questions were only asked to those 15 years and above, mainly due to ethical considerations. So once we collected the data, we then analyzed it, and we limited our analysis to those girls or young women who were 15 to 19 years across all the survey rounds. And we carried out a repeat cross-sectional analysis. So from 2018 onwards, we carried out repeat cross-sectional analyses for girls 15 to 19 years of age. So I'll explain this in more detail in the next slide, please. So before we go to the preliminary results, I had mentioned, I'll just explain to you. So we had 4 different time points based on the data that we've been collecting. So pre-COVID, what we did is we combined the AGIC and NICITU sample for 2017, 2018, and used that as 1 time point. We then used the data collected for AGIC and NICITU in 2019 as a different time point. And then we used the CAP adolescent survey for 2020 in the 3rd time point, and then 2021 in the 4th time point. So because we had a mean age, because we were only looking at girls 15 to 19, we saw that the mean age of those girls across the four different rounds. So both pre-COVID and during COVID, which is 2020 and 2021, was around 17 years of age. We asked girls across the different time points whether they were in a romantic or sexual relationship, and we can see that close to 1/3 across the different surveys or time points reported being in a romantic or sexual relationship. However, what we saw is this was slightly higher in 2021, so just under 40%. We then asked the girls across the different time points whether they were currently pregnant or thought they were pregnant. And we saw again around the response of yes averaged at around 5% across the different time points. We did see a small decline in 2020 to 2%, just over 2%. And then we then asked the girls whether they were currently trying to get pregnant. So we excluded girls who were already pregnant or who could not get pregnant. And what we saw across the different time points is over 90% of adolescents reported not wanting to get pregnant. And this didn't change much across the different time periods. Next slide, please. So this slide shows the percentages currently doing something to delay getting pregnant, and it only looks at those adolescents who reported not wanting to get pregnant. So what we see is on average just over 60% of adolescents reported using some family planning method to delay getting pregnant. And this is shown by the green portion of the stack bar charts. However, we saw a slight decline in 2020, and the percentage reporting using a family planning method, which went down to around 47%. But then by 2021, it picked back up. Next slide, please. So this slide shows the family planning method mix reported by the adolescent girls who had reported using some form of family planning. I'm only showing family planning methods that were most commonly reported. So the pill, injectables, implants, male condom, breastfeeding, abstinence, and emergency hormonal contraceptive. And currently what's really stands out is that we saw increased reporting of abstinence in 2020, 2021. So that's the second last group of bars, and compared to previous years. So we saw that less than 10% reported using abstinence as an FP method in the previous years. However, pre-COVID, but by 2020, 2021, this rose by more than by more than 30%. Okay, next slide, please. And this slide shows reasons for not using an FP method in adolescents who did not want to get pregnant. And we see that 70% or more of adolescents report that having infrequent sex or no sex was a reason for not using an FP method, which is shown in the green bars. So this was reported much more often than other reasons across the years, including health concerns about using a family planning method, and also costs and access to family planning methods. Next slide, please. So in summary, takeaway messages would be, we saw minimal actually to no changes observed in fertility outcomes. We did see a slight decline in number or percentage of girls reporting being pregnant, but then this picked up again in 2021. We did see a significant increase in reporting of abstinence, and we saw significant increases occurred during the COVID, so 2020 and 2021, which was quite different to what was observed pre-COVID. And we saw infrequent sex or no sex being the most common reason for not using an FP method across the years. Next slide, please. So in terms of limitations, what we would say is there is potential in this data for selection bias, because there was the interviews especially, well, for the 2020 and 2021 data, we only interviewed adolescents who had access to a mobile phone. Also, similar to the previous presentation, there is the question on, do different modes of data collection have an effect on the responses? So pre-COVID, we were doing in-person interviews, and then during the COVID pandemic, we were doing mobile phone interviews. So that could have altered the responses. We had some attrition or loss to follow up during the last round in 2021. So we do need to control for that. And yeah, we are keen to compare our findings to other studies and see, whether there's any comparisons or it's contradictory to what other studies are showing. Next slide, please. So just to acknowledge my team at the Poverty, Gender and Youth Program at Population Council Kenya, the girls and the parents from the cohorts who carried out the interviews, the enumerators, and also the funders, which include the Executive Office of the President in Kenya, University of California, San Diego, Innovations for Poverty Action, and the Foreign Commonwealth and Development Office. Next slide, please. Okay, yeah, that's it. Thank you.
Thanks so much, Beth. I think we'll go for a few more minutes. Carolyn and Pop Division colleagues have alerted us that we can go till about 12:45 or a few minutes over. So, but thanks so much for sharing this work, leveraging existing cohort studies to better understand family planning behavior and practices amongst adolescent girls and young women in particularly difficult settings like informal settlements in Nairobi. I see in the chat window a couple of questions and comments which have already been posed. So I wanted to draw a few of our speakers' attention to that and invite them to come in. Philip, I see there's a few questions and comments about disaggregation, particularly with regard to younger women and socioeconomic characteristics. Perhaps you could comment particularly about some of the findings from the recent published studies and the PAA poster that you guys recently put forward. And secondly, I wanted to, I think there's a question in the chat window, Beth, about the potential to adjust for selection bias in your sample. I think you mentioned it as a specific limitation of your study. And Philip and the PMA team shared some interesting approaches to adjust for selection bias. So your thoughts a little bit on how you might better address that. Over to you, Philip, and then Beth, and then we'll give also the Kristen and Jacques a few moments to make some concluding remarks before we close. Philip, over to you.
Sure, and thanks again for the questions. I think to start off, because I think a few of the questions I received were about various populations. I think the overall theme of what we found in our analysis is that there is a fair amount of variation across different subpopulations and geographic areas. It's tough to get into a lot of detail about that. But we did disaggregate, and I think all of the studies. So probably the best approach is to look at the studies that are posted online, and then feel free to, of course, contact me if you have specific questions or comments. I'd love to hear more. And then received a question about analysis of adolescents and the extent to which the results apply to them. And we are working on analysis of adolescents in particular, age 15 to 20, 15 to 19, and 20 to 24. And generally, we found results were basically the same as for the general population. And we've done analysis of the data for our second phase that recently just came in. So we have 3 data points for some of these adolescents from before COVID to the phone interview and then to 1 year out. or close to a year out for the pandemic. And results for that are also fairly consistent in terms of supporting results from our phone survey. So thanks again for the questions.
Thanks, Philip. Over to you, Beth.
Thank you. So in terms of adjustment for selection bias, as you saw under my limitations, we haven't done that yet. It's something that we do need to do. So one way we were thinking of doing it is being able to compare, the socioeconomic status and other social and economic characteristics of adolescent girls who did have phones and didn't, and see whether there are like huge significant differences across the different groups. But I'd also like to reach out to Philip at some point and kind of see how they went about controlling for biases. Over.
Thanks a lot, Beth. And before we shift over to Kristen and Jacques, just wanted to alert both Kristen and Jacques, but also Beth and Philip, a few questions from Carolyn and Francois from the POP division, specifically around fertility patterns of younger girls with regard to observed increases in child marriage during the pandemic. If you could specifically engage that. And then I think Francois is asking a little bit about the internal and international labour migration patterns and how that may have shifted household composition and therefore affected fertility intentions and outcomes during the pandemic. Kristen, do you want to jump in here?
Sure. I think I'm going to make my answer really short, and that all the questions directed me are good questions for Phil to add to PMA surveys. So those are questions that would definitely be interested to answer in a panel survey and not necessarily things we can pick up with serve statistics. But I look forward to analyzing the data when you release it, Phil.
Thanks, Kristen. And over to you, Jacques. Jacques, I think you might be on mute. Perhaps you could unmute your microphone.
Okay, thank you. Yeah, great. Apparently I did not receive any specific questions. And then what I can say that one of the challenges we may not mention in the measuring the impact of COVID-19 on fertility is the proportion of premature birth that could affect a measurement for the actual fertility if the pandemic is affecting both the use of health facility and also biological aspect. So we need really to be careful with the data and try to look at interaction between different factors. Thank you.
Great, thanks, Jacques. Any further comments from Philip or Beth regarding child marriage and household composition?
Sure. Well, first of all, I want to thank Kristen for increasing the pressure that we always feel with the constraints of putting together a survey instrument. So thanks for adding even more questions. But seriously, those are great questions. And in fact, we did measure regarding Francois' question on migration. We did actually ask women on the phone survey if they moved from the baseline. And we expected that one possible pattern is people moving out of cities to rural areas due to fear of infection. And we found that the percentage of women who fell into that category and who moved between baseline and follow-up was negligible in our studies. I think it was less than 5% in all of our contexts. So that again could change with longer duration of the pandemic, but we didn't find much internal migration, especially during that period.
Thanks, Philip. Over to you, Beth.
So I can comment a bit about early child marriage, though it's still early days, we think, but we did collect some data from the northern part of Kenya, Wajir, which has probably one of the highest child marriage rates across the country. And we didn't really see any increases in child marriage, but as again I say, it's still early days. Who knows, maybe if we are able to do another round of data collection, things might change, but so far nothing significant. Over.
Excellent. Thanks, Beth. Thanks, Philip. And I don't see any more questions or comments right now in the chat window. So maybe I'll take the opportunity to thank all four presenters for sharing these data and insights with us. And I think that concludes, we just went 7 minutes over time. So thanks for hanging in there and indulging us in a little bit of Q&A. I think that concludes session number 3. I think session number 4 is due to begin at 7:30 p.m. Eastern Time to account for colleagues in the Asia Pacific and Oceania region. So Carolyn, maybe I'll pass back to you in case there's any announcements before we close out for this part of the day. Over to you, Caroline.
Thank you, Romesh, and thanks all panelists for a very interesting discussion. I think we have already learned quite a bit in these couple of hours, and now we have time to digest. And yes, as you said, we have now a New York time, an evening session to accommodate the colleagues further in the East to make sure, to tell the world New York is not the center of the world. So I think it's. We all look forward now to that session at 7:30 New York time. As I said before, we will post the present session on the website, and we will also post those of you who will not be able to join us in the evening session. So you will also find that session posted, so you can also review that early tomorrow morning. And yes, put your thoughts into it. And thank you all. Take a break. Hope to see some of you later in the evening, and for joining us the next round of discussions to look at Eastern and Southeastern Asia, Oceania, as well as Australia. Okay, thank you all. Have a good afternoon, evening, and catch up later today or early tomorrow. Thank you all.